So my name is Andrew Pinto. I'm a public health physician and family physician at the University of Toronto. I practice clinically at the St. Michael's Family Health Team in downtown Toronto, about 25% of the time. But most of my time is spent on research. I direct a research team called the Upstream Lab that I'll mention, and I also serve in a couple of roles helping support clinical research as well. And today, this is a workshop on building successful grants for clinical trials in primary care. I always want to start with disclosures, just to be really transparent. Our research doesn't receive any funding from for-profit or commercial entities, but just to be transparent where I receive funding and where our team is supported. I want to begin, I think we're all joining from across Turtle Island today, but I'm located in Toronto, which is the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. And like many of us, my family came to these lands from elsewhere, from actually communities and lands that were colonized. And of course, this is not just a historic issue. This is part of an ongoing process around colonization. And whenever I do a land acknowledgement, it's a good reminder to recommit myself to things like the calls to action for truth and reconciliation. And also, because of the topic today is on research, to remind everybody about the OCAP principles that govern research that involve First Nation communities as well. So the objectives for today are really in a three-part fashion, are to review the key components of a CIHR grant application that's for a randomized controlled trial in primary care, to try to, through not only my presentation and the panel that we're going to have, but through our discussions, identify critical success factors and common challenges. And also to actually, in our last part of our morning here, is to actually develop a rough outline of the CIHR grant application so that all of you are coming away from this with something that is developed, whether it's your own idea or we do have an example study for you to also to work on. I wanted to note that this workshop today is focused on this topic, but there may be future workshops that we conduct, hopefully with many of you, on things like statistical methods, adaptive platform trials, doing qualitative research along trials, because I know at least one person attending had a particular passion for qualitative research, cluster randomized control trials and other areas. So stay tuned for future workshops, and we'd love to hear your feedback on really what would be useful. So today we're going to just start with introductions, which I've done. I'm going to talk about the key components of a project grant, and then we're going to take a break so everybody can have a chance to get up and stretch. And then we're going to have a panel discussion with three colleagues, Aisha Lofters, Michelle Griever, and Noah Ivers, who are going to talk a bit about their experiences and explore what worked and what hasn't. Then we'll take another break. And then when we come back, we're going to have people in breakout sessions where they are actually going to work together on developing a draft proposal and then actually come back and kind of talk through what were some of the challenges of putting ideas down on paper. So we recognize, in a workshop like this, it's hard to come away with a fully formed proposal. It's pretty unlikely. But we hope that everybody comes away with some things written down that are going to be helpful to you. So I mentioned that I direct a research group called the Upstream Lab, and I mentioned this partly because this is where a lot of my own research experience is based in conducting studies, including trials of social interventions that tackle the upstream factors that impact our health. But maybe more relevant to today is these are some of the studies that I've had a chance to lead or be part of, most of which are related to social interventions. But also I have this role around practice-based research networks that I'll talk a bit about. So What are practice-based research networks? Hopefully most of you are familiar with them and maybe are part of such a network. These have really grown over time in Canada, and we're now reaching almost a decade of having robust primary care practice-based research networks. These really help facilitate the types of randomized controlled trials and other types of clinical research that we're going to be talking about today. They are the kind of living laboratories that lead to discovery. They're networks of practices. So they could be practices, or they could be things like local public health units or specialty outpatient clinics or hospitals as well, where people are working cooperatively to address pragmatic research questions. There's a commitment across the network to improve health through systematic inquiry. And that the idea that our practices are places where research can happen. What helps to make them work is central coordination, where staff help support, say, things like research ethics board applications, data sharing, analysis, and that's what makes them efficient. So maybe people can put in the chat, are you currently part of a practice-based research network? And if so, which one? And if not, then just say, no, not yet. And that would be really, I think, interesting to just see for people to understand them. So I'll give people a moment to just try to enter that in. And it's interesting because you may not be aware if you're part of a practice-based research network as well, because sometimes particularly in primary care research, these have been happening sometimes in the background where they've had a strong focus on extracting and collecting and processing data from practices and are not as visible so I'm actually noticing some people who have said they're not part of a practice-based research network who I actually know they are. So it's an interesting point about us making sure we share and actually let everyone know that yes, you are part of a network, and yes, research is happening here. So part of why we've constructed practice-based research networks is to increase the efficiency in which we can answer questions. And it's a part of this broader idea of a learning healthcare system. So in an ideal state, what we would have is problems and ideas coming in, either internally and externally, developing ideas about how to evaluate the idea, implementing it, data being collected in a very efficient way, and adjusting. Normally, we think about this learning health system idea in the context of quality improvement, but I think actually it works even better for research, where we think about research and the research studies that we conduct as part of this learning healthcare system, where it is really a rapid cycle between idea and innovative solution to studying it, to disseminating whether it works or not. So the two networks that I'm part of, one is called the University of Toronto Practice-Based Research Network, and I serve as the Associate Director for Clinical Research. It was started now almost 10 years ago. It involves 14 academic sites with a large number of faculty serving over 1 million patients. And although its history has mostly focused on the collection and use of electronic medical record data, over the last few years, we've really built up the clinical research where we're now conducting a number of randomized controlled trials across these sites. And you can find out more about it at this website here. Maybe Jamie can put that in the chat as well. The other network that I'm part of is an Ontario-wide network called Poplar. It's made up of 7 different networks, including UTOPIAN, but all of the university-based practice-based research network, and also the Alliance for Healthier Communities, which are all the community health centers, Aboriginal health access centers, and others in the province. Collectively, we serve about 1.8 million patients. And what Popular has resulted in is also a provincial EMR database, but also a clinical research network. And I co-lead this with my colleague, Dr. Dee Mangan, who's at McMaster University. And you can find out more at the Popular website as well. So what we're seeing is, networks being developed at the local university level, and then also growing to provincial networks, and other provinces who are here have similar networks that are developing as well, specifically for helping support clinical research. I wanted to mention that one of the things that I bring to this work is also a very recent development, which is we received funding to conduct a very ambitious adaptive platform trial of COVID therapeutics. You can find out more at this website, but the Can Treat COVID study will hopefully really engage colleagues from BC, Alberta, Manitoba, Ontario, Quebec, and Newfoundland in studies of treatments for COVID. And also that this will help build our capacity to conduct these types of adaptive platform trials. So just to tell you a bit about who's here today, we had a lot of interest in this workshop, which is great, despite it happening on fairly short notice and during the summer months. We had mostly quite a few people from Ontario, Quebec, and the Atlantic, but also people from elsewhere. For the future, we'll make sure that the time works better for our colleagues in the West Coast, because I know that right now it's quite early in the morning for anyone on the West Coast. So we'll try to keep it in the center of the day in Eastern time, so it's easier for people. Most people who are here are faculty, but we also have some graduate students, research coordinators, and others. A lot of people have had some past experience as a co-investigator or collaborator or graduate student, or being a research coordinator on a study. And some of the things that people identified as goals: better grant writing, being able to write a credible proposal, strategies around funding, and tips on applying to a CIHR call. Part of why we position this workshop now is to help all of you with getting ready for the CIHR project grant call, which has the registration in August and then the full submission in September. So hopefully this is really useful for you as people are gearing up for that. Some of the areas where we ask people, what are your areas of interest, is quite a variety, which is really great to see. Everything from people studying brain cancer, chronic pain, environment and health, shared decision-making, and many other areas. So within this group of people, lots of different interests. What are our kind of motivations? So we really want to build our community and links to each other. We want to improve the chance that your excellent research ideas get funded. We want to really increase the number of applications to CIHR from primary care. So one of the, I think, key take-homes I would love everyone to take away from this and also share with your colleagues is CIHR receives very, very few applications from primary care researchers. So just on the basis that they receive few of them and the success rate is low, means very few end up getting funded overall. But the more that people that apply, the more will get funded, and also the more we will see reviewers who are from primary care research participate. So one of the things that's just maybe of interest to you is to take a look at who is on the review panels for randomized controlled trials. There are 2 RCT panels at CIHR. They are notoriously really tough places to impress people. But if you look at the membership, when I checked, it looked like there was no one from primary care on them. So it's a very tough space. But what happens is, as people get funded, you get invited to be a reviewer and a member of the College of Reviewers, and that will change the composition of these panels over time. And one of our key motivations is we really want to develop what we're calling kind of the Canadian Primary Care Trials Network, which is kind of exactly what it sounds like, is a network across Canada of people doing primary care trials. A lot of randomized control trials that are conducted with our patients don't represent the broad diversity of our practice populations. We, with some colleagues led by Aaron Orkin and others, we actually did an analysis of randomized controlled trials that were published in top journals, and the references there. And what we found is that the vast majority don't report on and don't really have a diverse set of people who take part. And as I mentioned, although we have limited data, we know only a small percentage of CIHR funding is actually awarded to faculty in primary care. Most trials that come to us in primary care are often led by people outside primary care who simply really want to help with recruitment. And one of the things we want to change with this workshop and with other efforts is to change that. One of the things I wanted to pose is thinking about the topics people were thinking about. Some colleagues helped develop this top 10 list of what are the most important unanswered primary care research priorities. And I would encourage everyone to actually take a look at this and consider, are there questions that really strike you as important in primary care research? And also, are they things that could be answered as well? So not necessarily only by trials, but really some key ideas here for key things to try to tackle. What we notice is a lot of the research that is proposed, including by people in this group and work that I've conducted, has been on primary care, how it's delivered, the quality, the financing, new programs or services or approaches, but all within primary care. What I'd love to move us as a field towards is research on key topics that aren't specific to primary care, like COVID or coronary artery disease or diabetes. That research that happens on these topics in primary care, because this is where the most people receive their care. So we know that primary care colleagues and practitioners often are concerned that the research that we're basing our guidelines and our practice on is not from within primary care. And so to solve that, we need to actually be doing research on these topics with colleagues who are specialists, but in primary care, because this is where people actually receive their care. It will make the research much more pragmatic and much more applicable to our work, and will reach a much broader type of selection of patients. So what we're going to cover today is building towards this idea of a Canadian primary care trials network. Our goal is to support primary care researchers to test, cool ideas that they have rigorously, to support people to be thoughtful site investigators. So I hope that all of you also get invited by one another to be site investigators on RCTs, and also to build a community of practice. So let me get into now some of the key components of a CIHR project grant for our randomized control trial. And one of the things is, and I think Jamie will put this link in the chat, is starting with the standard headings that CIHR requires. So if you submit a grant application for an RCT, you have to follow these headings. And what I'm going to do now is walk through these headings and talk through what they are and what they're useful for. Jamie is also going to be circulating to attendees a Word document that has these headings. You could also just copy and paste it from the website as well. But we thought actually giving you a Word document will make it even easier. And what you can do is either fill out some points as we're talking through them, or and what we'll be doing in the later part of today is actually putting in information under each of these headings so that you're coming away with an idea. So let's start. So really there are 3 sections to this proposal, and you have to think about it as likely about a 10-page proposal, like single-spaced, 12-point font that you're going to be submitting to CIHR. I always recommend when you're putting in a proposal is start with a very brief summary of the entire thing in literally maybe 4 or 5 sentences. So this could be something like, our team represents, people from across Canada or these provinces, and we are going to study the really important issue of, insert what this is. And we're going to do this by testing using, insert study design and evaluating this option versus this option. And this is really crucial because we actually have no idea what works, or the evidence to date is very limited, or nobody has studied this. And over, what this will end result, this will change practice, this will change policymakers, things like that. But starting with that is so key, because before people get into your proposal and get lost in it, they just know at a glance what you're talking about. So the CIHR headings really start with 1.1. What's the problem to be addressed? This is really important to make succinctly, because I would say the number one reason that grants are not getting funded is simply because they are not that exciting to reviewers. When reviewers are looking and they get a stack of proposals, maybe 20 or 25, and they're reviewing them, if this is a problem that doesn't excite them, that doesn't seem to be that interesting or relevant or important, it just right away is not going to be that interesting to them. So pitching the problem as really essential and amongst the most important, needs, things to get funded is really quite key. And what I would encourage is that this is not necessarily the need to put in pages of the background and rationale. It's really kind of a short synopsis of the issue and the equipoise or the lack of information to date. So just really briefly, 1.2 is pretty straightforward. What's your research question? And in randomized controlled trials, we have it quite simple, where we're stating, we're studying whether or not this works compared to this. And what's the effect of it? Sometimes also what's the cost effectiveness? But you can usually state that very succinctly. 1.3 is also, one of the most important areas. Why is this trial needed now? What is it that's so pressing that that demands that this get funded now? One of the key points that CIHR makes is you can cite evidence from systematic reviews. And maybe another take-home point that I would make is, and I often talk about this with graduate students and early career staff, is that is really consider as a first point is conducting your own systematic review and publishing it in a topic area. That establishes your understanding of the literature, but also is something that establishes you as a bit of an expert in this area. So unless it's already been done, it's really worthwhile that being considered as a key first step. And also they note, if you don't think any previous trial has been done, attach an appendices that actually demonstrates your search strategy. How did you try to search, not only Medline and PubMed, but also clinical trial registries and others to identify whether or not existing trials have already happened. 1.4 is how will the results be used? This kind of a key point of this is who on your team is a knowledge user, who will ultimately want to use the information that is judged. And this is maybe a second key area of why things don't get funded, is because you haven't included on your team and have a letter of support from someone who's ultimately going to be making use of what you've discovered. This could be not only, we often think of like a policymaker who are often hard to reach, but it could be someone who's developing a clinical practice guideline in the area. It could be a leader of a primary care organization like the College of Family Physicians or similar, but that's really key. And how will they be used? How are you going to translate your findings beyond just publishing a paper into actual guidelines or policy or something like that? What are the risks? So this is often, the good news is often in primary care, trials, we're not doing things that are of enormous risk to participants, but it's good to kind of think through, are there risks for people being denied care? Are there any kind of unintended risks as well? So some kind of suggestions from CIHR, and again, this is actually on the CIHR website. Think about present and future resource implications for healthcare. We have this benefit in primary care where we know that if primary care is robust and high quality, it ultimately leads to savings in the rest of the healthcare system. So that could be a key part of your rationale. And also, when you're thinking about the data that you want to collect, are you collecting administrative data that will help you understand the impact on healthcare spending? Obviously, you need to be clear about specifying your objectives, your questions, and hypotheses. Is the trial addressing the right question? This is kind of, it seems really obvious, but this is where it's asking really what's the most important question in this area that should be answered, and is that the most useful use of funding? You have to think about it like if CIHR is only going to give out funding to maybe the top 12 to 15%, why is your trial and proposal more important than 85% of the others? And why is that the right question? It's a kind of a daunting, thing to ask yourself, but it's actually trying to be very honest about that. Is this the best use of funding? Is this the right time? So what is it that makes it the right time to do this? We're facing many different crises right now, but why this? Are there reasons for the study and changes really explained? Did you go through the process of thinking about how the findings are going to be translated into practice? There's a mention about the systematic reviews, and again, just underlining that point that you may want to do that as a first step. Is the research compatible with what we know already, both nationally and internationally? And ideally, do you have some people on your team who have maybe been experts in this area and can really attest to that you have a group of people, including folks from outside Canada, who could say, yeah, you know what, this is really needed now. What impact will the results have, and will the results be generalizable? This speaks to who will be included in your study and why it's really hard to get, say, a single site RCT funded, where one of our benefits of our practice-based research networks they are involving a wide variety of practices from across Canada and engage very diverse folks. So it really helps with the generalizability. One of the things I would say is it's probably almost always going to be the case where when you're making a proposal to CIHR, that you want to include at least 2 different provinces, if not more. So I hope today and through this workshop, one of the things is that you start to build your network and set of contacts. And also, as we move ahead with this Canadian primary care trial network, it will help hopefully connect people to one another. So that's all kind of the first part, the rationale. And I would say usually this is about maybe 3 pages out of the 10-page proposal. If we then move to really the meat of the proposal, which is maybe pages kind of, 4, 5, 6, 7, 8, it's really this section now, the proposed trial. This is the methods. One of the starting points is this idea of doing a PICO framework. So what is your population? What's the intervention you're going to study? What will the control group get? What are your outcomes, both your primary outcome and secondary outcomes? And what's the timeline that you would want to see this change in? Like, is it in 6 months? Is it in a year? And so on. So I'm just going to go through these different items now. So the first is really, what's the proposed trial design? This is usually fairly straightforward. It's not an elaborate description. It's usually like 1 or 2 sentences where you say, well, this study will be an open label, individual level, single-blinded RCT, that will engage X number of sites or something like that. This is also where you would put in, are you doing an individual or a cluster randomized control trial, or or some variation on that. And one suggestion is to actually put your PICO right in a little box right at the start of this. It helps the reviewers. What are the planned trial interventions? Obviously, this will link to your first part where you talk about why you're doing this trial. But what will the experimental group receive? What's the control group? And if you have multiple arms, what will be happening then? But this ties into, again, the rationale for the study. What's the proposed practical arrangements for allocating participants? This is where you speak to how will you randomize. And this is where having someone on your team who's a statistician, who's going to be actually conducting the generating the randomization sequence and assisting with that would actually come in. Usually this is where you say, we're going to use some form of randomization, block randomization, or other, and it will actually be built into the process of engaging patients in the study, and then they'll be randomized at this stage. If there's stratification, where you are saying, we want to really understand how this works for men or versus women, or for people of different economic groups or others, you would explain to it at this stage, and also give reasons why that's happening. What are your proposed methods for protecting against bias? So this is where you may want to talk about who will be blinded. Often in primary care research, what I've noticed is it's impossible to blind participants to which intervention they're receiving. So sometimes that's just not possible, and it has to be an unblinded study. But the people involved with the analysis may be blinded to which group people are in. So there are different ways, but there are other things around bias that can be used and discussed in this section. There are many forms of bias as well, including, how will sites be selected, how will participants be selected, and how to deal with that. What are your planned inclusion and exclusion criteria? Is usually pretty straightforward. We will be including adults or people who are 18 and over who have this condition, who are identified in this way, and they will be excluded, for example, if they're already participating in a study, or if they have these conditions, and so on. What's the proposed duration of treatment? So how long will people be receiving this treatment? Will it be a week? Will it be a month? If the treatment or intervention is a type of service like psychotherapy or a new type of health promotion service, how long will that go on for? And related to that is, how often will you follow up with people? Normally we have information at baseline that's collected, and then it's going to be compared to some other time point, and that allows you to understand what the effect of the intervention is. Will you have multiple time points that you're following up with people? And what that relates to is 2.8 then. How does that relate to your primary outcome measure that you are considering? At what time point will that primary outcome be measured? And just some points on that. Why did you choose your primary outcome? It can't just be because it was easy or feasible. It has to be really the thing that was considered important by patients, policymakers, or providers. This is where there's a couple of useful resources. There's an international network on health outcome measures, International Consortium on Health Outcome Measures, called ICHOM, that has assembled key outcome measures across a variety of health conditions. So that is often a really useful starting point. These could be outcomes that have been identified by patients as really important to their quality of care. These could be also key outcomes for policymakers, such as the number of people who have access to primary care, or number of people who are ending up readmitted to hospital, or things like that. And how will the outcome measures be measured at follow-up, and is it feasible? So we actually have a limited number of options for measuring outcomes. You can, at consent, at the very initial start, when you consent people, you can ask people for their permission to follow them using administrative data. The benefit of that is you never need to connect with them again. You essentially use their health card to help follow them in time. A key obvious downside to this is it's limited. It just tells you about their healthcare use. And also often in, I think, most of our provinces, there's a big time delay. And some provinces, I'm thinking particularly of Quebec, may face significant hurdles around permissions for people to actually access that data. I think Saskatchewan is another province where it's really can be challenging. So that's one, though, approach. The most common, so there's admin data to help to follow people up. Probably the most common is where you contact people again, where you say, I'm going to follow up with you at 3 months or 6 months or a year, and re-administer the baseline measure, which is going to be your main outcome. The obvious benefit of that is you have a human who's reaching out to people to collect the data and bring it together. And also because it's a human, you can engage in quality control. The downside, the biggest downside is feasibility, and it's an enormous amount of resources to have a research staff follow up with each person in the study. And it's really important that you calculate how much time that will take and you build that into your budget. Otherwise, it's just not going to be feasible. So you think about it like, okay, how much time will it be of staff time to consent and complete baseline data? And then how much time will it take to follow up with people as well? And do I have enough funding to do that? And obviously, people change their phone numbers, people change their addresses, people are lost to follow up in study as well. A third option, which I think is actually relatively underused from what I've seen in primary care research, is actually patients actually completing short surveys themselves or diaries of their own symptoms and using electronic methods to return that. So that's another option in terms of outcome measures to help follow up. Again, a huge downside, of course, is that some people may just not bother to complete the surveys or diaries, and you have to try to pursue people as well. So then moving to the next point, what's the proposed sample size and what's the justification? So in both the control and treatment groups, you need to think about what is your estimated power calculation. This is where working with your statistician will be key. And there's a variety of different ways to estimate sample size, but I'll just walk through kind of the most general approach. One is first thinking about what is your primary outcome that you're looking at and actually finalizing that. Even though there may be many secondary outcomes, the whole sample size could be powered using your primary outcome. The next is saying what do we expect the baseline to be in this population? If we are using an anxiety or depression score, a quality of life measure, a symptom severity index, health service use, any kind of measure, even or side effects or some of the measure, what is the baseline? And that is crucial that you are citing studies that have been done in this population that tell you what the baseline is to expect. If those studies haven't been done, that would be a key area for you to consider doing pilot work to actually just understand in your population that you're going to be studying what is the baseline of this. It also actually demonstrates that it's feasible to collect data and that these tools make sense to people that you're using in this population. I'll come back to that idea of pilot work a little bit later. Then the next question is, what do you expect the anticipated difference to be from baseline to the follow-up period in your primary outcome for the people who receive this treatment? Do you expect it to lead to a 10% difference, 50% difference? How big of a difference do you expect? What is your understanding going into this trial of what you would expect? The thing that helps guide that is what is clinically meaningful? What is a meaningful change in this outcome measure? is it meaningful to see a 2-point drop in the scale? Does that really matter? Does that make any kind of difference? To help really guide that, that's where also thinking about other interventions that have been studied using this tool is really helpful. So a good example of this is where you may be studying, say, a psychotherapy or counseling intervention, and you are focused on people with anxiety or depression. And what would be meaningful would be would be like, what is the change seen, say, if someone took a medication for these conditions? And what did people see as a change in this type of score for them? A suggestion is to consider including a small table that has sample sizes for the control and the treatment group, and obviously sums to your total sample size, that with varying power and effect size, and then using a more conservative approach. So it usually resonates well if you say, we conservatively estimated our sample size by using, actually saying we expect to see a fairly modest change, and we want to have power to detect that difference. And cite pilot work that you've done or existing studies. It really doesn't go over well if you just say, well, we think that this will do this. You really have to back that up. So this is another key area where I think grants get rejected, is when they haven't fully justified the power calculation, or when you have done this and you realize you need such a massive sample size, and then it becomes unfeasible. So it's a key balance. Just to continue, so are health service research issues being addressed? This is where you are considering, are you looking at health economics, and are you doing an economic evaluation of the intervention alongside the trial? Do you have on your team someone who is a health economist, and have they helped develop this section of the study? And I could envision a future workshop being actually focused specifically on doing an economic evaluation alongside a trial. How are you going to collect information on things like the cost of the intervention, the cost in terms of, say, health service use, and also the quality of life measures if you're doing, say, a cost utility analysis? What's your planned recruitment rate? So how will you recruit people? This is where I think practice-based research networks really come in, and where what we're doing is developing a track record with practice-based research networks to say, we have recruited successfully for these different trials, and this is the anticipated recruitment rate that's possible. But this is often a really key area, and allowing enough time for startup and a relatively slow recruitment rate so that it's possible. Are there issues with compliance? This means, like, are people, if it's say like a medication or a drug, is there any issues that people report that they are unable to continue with the treatment, that they stop it? A lot of things that we study in primary care it's less of an issue, the issue of compliance. Usually people are actually able to go through with what we're proposing. What's the loss to follow-up rate, and what's that based on? So what do you base the fact that will you be unable to follow up people for that data collection? And this is, again, where pilot data comes in, and inflating your sample size to account for loss to follow-up. So it's saying we anticipate like a loss to follow-up rate of, say, 15 or 20%. So we want to make sure we have a sample size that accounts for that. Obviously, if you have a lot of missing data, that will play into your analysis, and also that may lead to something else, and you don't want to have a high loss to follow-up, but it's important to consider that. And how many centers will be involved? So how many clinics do you think are necessary? So again, something that's really neat with practice-based research networks is we can actually use the EMR data we have to estimate how many patients in those practices would be eligible for this study. And we've done this for other trials where we say, we're doing a trial which requires, say, 200 people. And we can say within these practices that we're going to involve 4 practices, we know we have 5,000 or 6,000 people who meet our criteria. So it presents as really feasible that you could include it. I wanted to share this set of criteria that we've developed at UTOPIAN around what are the roles of different people on a site. So there are responsibilities of the principal investigator, which many of you will be the ones leading the study, but there's also responsibilities for the site investigators and things that can be done to help make their job easier. So having this, and maybe Jamie can put in the chat the link to the UTOPIAN site that has this as well, if you want to refer to it later as well. What's the proposed type of analysis that you will be doing? Often, this is again where the statistician on the team will be coming in, where you're talking about how will you compare the baseline to the follow-up period, and how will you consider other factors that could be influencing your analysis. The frequency of analysis would it be, are you, in addition to doing your analysis at the end of the study, are there any interim analyses? One of our biostatistician colleagues at the University of Toronto made the note that to be very careful with the idea of doing multiple interim analyses, because it actually means that you need a much bigger sample size to address that as well. So usually it's more simple to say, we're going, unless there's a safety reason to do interim analysis, or you're doing something like an adaptive trial, usually it's an analysis at the end of the study. Are there any planned subgroup analyses? So this is, as many of you will know, CIHR requires us to talk about sex and gender considerations. And this is where you can talk about how you will disaggregate and actually look to see, does the intervention have a differential effect or impact on men versus women or other areas as well? And has any pilot study been carried out? This is where, again, one of, I think, the take-home messages is to help you be successful with a CIHR grant for a trial. It really is helpful that, say, you have done a systematic review of that area that's up to date and published that, and that you've done some pilot work. The pilot study work can be done to help with your sample size calculation, help test your instruments that you hope to use, help test your recruitment processes. What's your rate of recruitment? Help with testing your informed consent materials, and many other things. So quite a few of the studies that we've done have actually been where we first did a pilot study first. So some of the things that reviewers are going to be looking for: is the study designed appropriate to answer the research question that you posed? Have you taken account issues around generalizability? That's another one of the major areas that I think reviewers criticize, is that this sounds all really interesting, but it's not going to be generalizable. What is the justification that's underlying your power calculations? Did you just make that up, or is there some evidence that you're basing it on? Are the outcomes and measures described? Have you defined the trial population? Have the measures been validated? Is the control group appropriate? And how will you consider sources of biases as well? I know that this seems like a lot of really tough questions to answer, but these types of questions, when you are asking colleagues to do a review of your grant before you submit it, this is the type of thing that would be really useful to help to guide their review of it. I'm going to just move to the third and last section, then leave a few minutes for questions. The third and last is really about how you're going to manage your trial. And it's really a very short section. So I'd say maybe the last 1 or 2 pages. What are your arrangements for day-to-day management? Who is actually going to be in charge of the trial? Who will oversee it and oversee the staff that are involved? Who's going to be in charge of the statistics side and the data handling? And how will you do that? Most in Canada and other countries, we're moving to electronic case report forms that are essentially surveys that allow us to collect the data electronically, store it centrally, but all the details around that. This is where also working with an academic or commercial research organization is really helpful, that they're the ones who help with launching the studies. What's the role of each principal applicant, co-applicant? Obviously, this is where you can highlight your expertise, past experience as well. And finally, how will the trial steering committee be developed? And also, is there a data safety and monitoring committee? That's actually external and usually should be made up of somebody or some small group of people who is not part of the study team. So they can really be an external voice on dealing with any data safety or issues that come up. Just a few last slides on this. So how, does the team have the necessary disciplines and experience? Does it include people with experience with large trials? This is also where, the Canadian Primary Care Trials Network will hopefully be a place where you find others who have experience, particularly if you're just getting started. Do you have statistical advice, and is there a statistician on your team, and so on? So some kind of key challenges. Again, I mentioned, is this problem that you want to study really important, and will it resonate with reviewers who are not in primary care? This is, I know, a tough question to ask and to answer, but it's really good to be honest about it. It also helps you save a lot of disappointment that CIHR may not be the place to go and spend your time. Recruitment is absolutely the #1 challenge for trials. So how are you going to really think that through? And some people who you want on your team, you want site investigators who are going to be the ones who are helping with recruitment. And ideally, you'd like each of them to provide a letter of support saying, we think this is important and our clinic is going to take part in this. You want experienced team members, but you also want to be building capacity. You want to have learners and early career researchers involved as well. Just a note, if you're including graduate students or is just to specify, are they already funded, or are you actually planning to fund them using the budget as well? Knowledge users, as I've mentioned, a statistician, health economist, really key. Some just overall tips. Be very clear and concise with your summary. This is a really overlooked area, and it's important that it's a 1-page kind of summary that's very clear about your key areas. Really think through the sex and gender-based analysis because it's actually a key part of the reviewers, and they will always comment on it. Really consider trying to include preliminary data in an appendix. So if you have done a pilot, why not include it as an appendix? Make sure your budget is reasonable. So I think actually CIHR grants, often you don't have a lot of room to explain a budget. Usually you can attach an additional document, but be mindful that reviewers will actually really scrutinize it and really think about what is required, and also give yourself some buffer room because things always take longer than you expect. Don't mix up bolding and underlining and things like that. Just try to be consistent. And lastly, I would take a look at the CIHR peer review manual just for tips. So we're gonna now just give people a few minutes for any questions that they had that came up for this part, and then we're going to take a few minute break. And then have them each present kind of their thoughts as well. So I'll just start with, I should say, and maybe to disclose, these are all three amazing colleagues of mine who I've learned a lot from and I've had the privilege to work with, and really appreciate their time today. So Dr. Aisha Lofters is a family physician at Women's College Hospital and the chair in implementation science at the Peter Gilligan Center for Women's Cancers at Women's College. She's also an associate professor at the University of Toronto and an adjunct scientist at ICS. And she has developed a really amazing program of work around cancer screening and prevention and health equity, and she uses a wide variety of methods in her work. Dr. Michelle Griever is a family physician and primary care researcher at the University of Toronto. She is part of the North York General Hospital Family Practice Group. She serves as the director for UTOPIAN. So I have the privilege of being reporting to her in my role with UTOPIAN. She has done an amazing job of leading UTOPIAN, and she also is now the lead and really the founding lead of Poplar, which I mentioned earlier on. She also plays a variety of different roles with the section of researchers at the College of Family Physicians. She has helped lead national diabetes work, and also more recently has been part of the Ontario Health Data Council as well. So she has a lot of amazing leadership roles. And then Dr. Noah Ivers is another colleague. He's a scientist and holds a Canada Research Chair in implementation of evidence-based practice at Women's College. He is also an adjunct scientist at ICS, and he's really a world leader in the idea of improving performance of primary care and using things like performance measurement and feedback to support quality improvement. He has, in many ways, kind of literally written the book or written the papers that have helped define this area. So we're really privileged to have all three of these folks join us. And I think what we'll do is actually start with Dr. Lofters for your thoughts and insights on conducting, clinical trials within primary care, and any thoughts, and then we'll go to Dr. Griever and then Dr. Ivers, and then open it up for questions.
Sure, sounds good. I do have slides, so if you bear with me, I'm going to try and share them. Are you able to see that? Yep.
Yes.
Okay.
That's great. And if you just want to put it in presenter, that's perfect.
Perfect. Okay. So thanks, everybody. So Andrew did do an introduction. So I'm a family doc. I did my PhD in clinical epidemiology and finished 10 years ago now. Feels like shorter than that. I've really primarily been a quantitative researcher. So as Andrew said, I got a position at ICES. I do a lot of administrative database analysis, and that's kind of been where I started in my first love in research. My research really has been focused on cancer screening and prevention, specifically for populations that experience marginalization, with a focus on folks who are foreign-born and or racialized and or living with low income. ICS is really powerful because you're able to do a lot of descriptive work looking at literally millions of people. But after a while of doing description of health inequities, you realize that you're seeing the same things over and over again. And this did push me in more recent years to get involved in qualitative research to try to understand the why for the disparities that I was seeing, and then more in very recent years into implementation science, moving into interventions to try to actually address the inequities that were being seen. And as a family doctor, looking at health inequities, primary care really is a great place to tackle those inequities. And as Andrew mentioned, I'm a scientist and based at Women's College Hospital. So I'm just going to quickly talk about two trials that are currently ongoing within primary care, and then just mention a few lessons that I personally have learned when it comes to grant writing and also even just the process itself. So both of the trials that I mentioned on this slide are called, had the word better in it, you might have noticed. One is Better Wise, one is Better Women. So just going to very quickly, just for context, to let you know what better is. It's a focus on prevention and screening. So focusing on prevention and screening of the kind of the biggies for chronic diseases. So cancer, diabetes, heart disease, et cetera. And also thinking about the associated lifestyle factors. So diet, physical activity, smoking, and alcohol. It's targeted at people who are aged 40 to 65, because that's when we tend to focus on those factors and when a lot of those guidelines overlap. And really it's based around this idea of somebody in the primary care practice who's called a prevention practitioner, who meets with patients for a one-on-one visit. It's a long visit. It can be up to an hour, really going over their entire health history and helping them to set health goals for prevention and screening. So the Better Wise trial, which is one that is just wrapping up right now, is a pragmatic 2-arm multi-center cluster RCT that has taken place in 13 primary care practices over the last few years. So across the country, 6 in Alberta, 4 in Ontario, 3 in Newfoundland and Labrador. We had an average of 4 family docs per practice. And the intervention really was this idea of the prevention practitioner meeting with patients, using their tools, and hopefully increasing and improving screening and prevention activities by holding these prevention visits and preparing a prevention prescription. What we were looking for is basically at the end of a year, did we see that people who had worked with a prevention practitioner had better outcomes when it came to these prevention and screening actions? So essentially, the patient gets invited for a visit. They fill out a very detailed health survey. The prevention practitioner prepares for that visit, and the prevention practitioner is somebody in the primary care practice. So typically a nurse, but could be a health promoter, could be an RPN, a dietitian, et cetera. They hold that visit, and the patient gets linked to resources, including getting linked back to their primary care provider. So perhaps they've been seeing their provider who's been putting out fires, but they've not had a chance to really focus on lifestyle and screening. And this is a way for the provider to get brought back into that loop. That's Better Wise in a nutshell. Better Women is a similar focus where it's based on better, but now it's adding in the idea of a 6-month-long peer health coaching intervention. So with the original Better, people meet with a prevention practitioner for one visit, and then they can be on their own. Whereas with Better Women, we're adding in the idea of working with a peer health coach for 6 months to see if that helps to improve the screening and prevention activities. So again, this is a pragmatic, meaning it's, we're doing it in real life and seeing how things go, waitlist control trials. And we're working right now with 3 family practices in the GTA, and we're focusing on women, as you could tell from the title. So they get matched with a trained peer health coach after their Better visit and work with them for up to 6 months. And we're supporting patients in their goal to achieve, again, those 4 biggies for lifestyle, and then to see if we see any improvements when it comes to those activities and breast, cervical, and colorectal cancer screening. So those are 2 kind of very big trials that I'm involved in right now. So just wanted to reflect on lessons learned from both of those processes. I know the focus here is on grant writing, but also I'll just talk about once you get the funds, which can be a double-edged sword. So the very, very first lesson that I would say that's most important, as you can see by my team of superheroes, is you have to assemble a team of experts. So with Better Wise, that work really was spearheaded by Dr. Donna Manka, who's a family doctor in Alberta, who's done a ton of trials within the primary care practice. For Better Women, that expert who I lean on is on this call, Dr. Noah Ivers, who you'll hear has tons of expertise with randomized trials in primary care. So it's really about bringing people together who know what they're doing, quite frankly. You've got to have a statistician, you have to have people who bring expertise in each component. You come together, and that's your super team of experts. That applies both to the process of having the grant itself, but also to writing. So make sure that you have people, that you're not floundering when you're writing, that you bring people in who can help you with particular sections, and also to show the review panel that you've got the right people there on your team. They want to see that you've got the right experts for each component. When it comes to grant writing, give the reviewers what they're looking for. This sounds straightforward, but I read through grant applications in detail, and if they have evaluation criteria, I make sure that every single one of those criteria is being hit in the application. Use their exact words, feedback exactly what they're looking for. Don't make it difficult. No need to get poetic, because I always envision a very grumpy reviewer reading my grant at 11 o'clock at night. I want to make things as straightforward and easy for them as possible, so that even if they're grudgingly giving me a good score, they're giving me a good score because I've given them exactly what they wanted. Grant writing is not the time for humility. So this is not the time to be humble. You really are selling yourself and your idea. You're pitching this idea for a reason. You think that it's strong. You think it can make change. You think it's innovative. So tell them so. Tell them why you've got the best team. Tell them why this is the greatest idea. in the world, because you want them to get excited along with you and to fund it, and to recognize that this is where the big change can happen. And then finally, I would say anticipate what can go wrong, because it probably will. I could spend a lot of time telling you with both Better Wives and Better Women, with COVID-19, how that drastically affected our plans, how it affected staffing, targeting, recruitment targets. We've had lots and lots of ups and downs of both of those, because things can and do go wrong. So you want to anticipate that for when you get the funds, but also when writing the grant, you've got to be honest and open about your limitations. You've got to show the reviewers that you do see that things can go wrong and that you've got a good mitigation plan for it. So you say, here's what can go wrong, and if it does, here's what we're going to do about it. And again, you want to show the reviewers that you know what you're doing. And by being able to anticipate what can go wrong, it's not seen as a weakness, it's really, really seen as a strength. So those really are my key lessons learned. So I'm going to stop sharing now.
Thank you so much, Aisha. That was really fantastic, and really conveyed a lot about your past work, and also about some suggestions for folks. We're going to go next to Noah to share kind of his experience, and then we'll go to Michelle after that. But Noah, yeah.
All right, great. So I will try to grow my hair long, and thanks for that, Aisha. I have a couple slides too, and I'll try to not replicate what was already said. I had a feeling you would talk about better, so I didn't plan on talking about that. So that's perfect. You can see the title here. It's quick talk on trials. So we'll be quick. And I want to highlight some challenges that arise, hence the title there, and hopefully help you guys get around those. Some of them, I did tune into what Andrew was saying, and he helpfully talked you through the sort of bullet points that's in the standard kind of CIHR guidance about how to write up a trial. And that really does cover quite a lot. So obviously, if you're applying to the trials committee, you have to follow all the trials write-up rules. But you'll see towards the end, I think I would, strongly consider looking for special funding opportunities. I'll circle back to that.
That's a great point. Noah, do you want to just put it in presenter?
Oh yeah, sure.
But that's a fantastic point to note, which is that RCT committee is not the only place to get funding for trials.
Yeah, I will come back to that. So the first thing I want to emphasize, and I know that Andrew had it on his slide, is really how important it is to do pilot work. First of all, the reviewers look for it. But, so they want some amount of data, to prove that there's a problem worth fixing, to prove that you can collect data, and ideally to prove that you can implement whatever you want to implement. And most specifically, to show that you have some idea of the challenges related to recruitment. And Aisha touched on the challenges related to recruitment. There is no such thing as a trial where recruitment is easy, except for some that I'll talk about that sort of work around that a little bit in creative ways. So there's one trial that is very different from most of the other trials I've done. It was a true primary care trial of a novel intervention. It involved a few UTOPIAN sites and other sites. That's sort of the one on the left there. It involved looking for atrial fibrillation in people without a prior diagnosis of that, using a novel technology. And so, with this kind of classic trial design, you need feet on the ground. It is really hard to recruit without feet on the ground. And you need to budget for that, account for time for that. Just asking, family docs here and there to keep in mind that when they happen to see a patient like this, the one day a week that might potentially be eligible, to remember to refer them to your study and hope that that leads to a yield is really, really not going to cut it. And so if you are going to go that route, then you need dozens and dozens of sites because your yield at each site is going to be low. Alternatively, you can go to these sites and, work out a more effective recruitment strategy. And that's why I have the pilot study on the same slide as this slide about this study, is that, in my opinion, for trials, the most important thing to pilot is how the heck are you going to get your patients enrolled? And I would just like, if you leave this with one lesson learned, it's that recruitment is hard. And you cannot put enough focus on it. Okay, a couple other things I just want to emphasize around how I've worked around that. So most of my trials are very non-traditional. They are implementation science trials, and here's a bunch of them slapped on here that I quickly pulled together. And they are highly pragmatic and often do not involve recruitment at all, because, as I said before, recruitment's bloody well tough. And how do you do a trial that doesn't involve recruitment? Well, in my situation, you do a trial of something that's low risk, low burden, aiming to improve quality of care. And so there are specific stipulations in the TCPS2 and other relevant guidance around when you might seek what is colloquially termed a waiver of consent, but the TCPS2 has a different way of they don't use the word waiver, but that's basically what it is. It's an opt-out approach. And so in many of my trials, we send some stuff to some family docs and other stuff to other family docs, or some family docs don't get any stuff to try to help them improve their quality of care. And we want to compare across those groups. In such a trial, the participant being randomized is the family doc, but of course the patients they care for are where we measure the data. And so that just brings me to, one of my next points is just to emphasize what Aisha talked about. In trials like that, there are complex analytical and methodological implications. And you really do indeed need a team of folks that are really savvy with not only the ethics, which I'm sort of alluding to as it relates to consent, but also the stats when it comes to these sorts of trials. So please do build those superhero folks, whether you're Marvel or DC, I don't care, but it does need to be a team. So typically I do pragmatic cluster trials to answer the question in the chat. But then that's what all of the ones here are. And they might cluster at the level of the family doc with patients clustered within that, or they might cluster at the level of the clinic with many family docs and many patients within each of those. So it depends on what the risk of contamination is of the given intervention. Happy to come back to that if you want. So a couple other things I want to highlight to leave you guys to go away with. In order to do, a series of trials like this in what I call my implementation science laboratory, it really does require a partnership. And so I look for health system organizations or situations that basically an existing sandbox in which there's already toys, and I can add questions about, which toy works best. And so for me, the sandbox I like to work in is, working with organizations that are already funding quality improvement initiatives like Health Quality Ontario, Public Health Ontario, this sort of thing, and help them embed, questions that can be answered with a trial into that work. So is their initiative working at all? Well, maybe that's not the right question because they're bound and obliged to roll this thing out. But maybe the question is, how do they optimize it? Can we do it in version A or version B? See which one's better. And I think with almost all relationships, compromise is necessary. But one of the reasons for this comic is that there are some areas where you don't want to meet halfway. So compromise is not appropriate where it might invalidate the results, where it might harm your credibility as a scientist. It's not worth it. So your job in that scenario is to say, look, we ruined both of our outcomes here if we meet halfway. This is something I need to hold firm on. I can adjust on other areas. And you really understand where your partner is coming from. And this doesn't just apply to implementation science laboratories where you're partnering with health service organizations. It applies to, whether there's co-investigators or other knowledge users or patients engaged or whatever. There's a whole, I think, understated and underemphasized process of like really understanding where your partners are coming from and deciding which issues you're willing to relent on and which issues you won't. And I think, hold firm on issues of that could create bias and affect internal validity. That's sort of what I want, the purpose of that slide. And then I alluded to this earlier, and this is, I think, my last slide. You may not be able to read that. It says, geez, these grant review panels are getting pretty tough. So it's a bunch of, if you can't see it, it's like the 3 horsemen, symbols of death and stuff like that at the review panel. And I think that's kind of like the CIHR trials panel every year. They fund 1 or 2 trials at most. You're competing against folks that, typically have like tens of millions of dollars, folks like Andrew, who have tens of millions of dollars of, trial-based funding already. And if the committee is going to give it to somebody, they're going to be like, well, who are we going to bet on? We can only bet on one horse. So it really is hard to compete in that committee. You really have to be well prepared. And so my suggestion is to look for special funding opportunities. And there are some that arise for special disease conditions, for primary care in general, for special kinds of interventions like e-health. Things come up. And you want to be ready for those and put yourself in the right position. Sometimes that means putting everything down and, as Andrew did recently, like just pulling a team together super fast and taking advantage. It can really pay off. So try to be ready for special funding calls would be my my other take-home point there. And I think that's all I wanted to say. I hope I didn't take too long, Andrew. I know I had a limited amount of time.
No, that was fantastic. I think, both you and Aisha really did great keeping to time. And thanks, Noah. And I was just going to mention that I think almost all of the work that I've done has been funded through special funding calls or similar, rather than all, from CIHR or similar. But yeah, and so someone asked a question, what's the sources of these special funding calls? So they are from CIHR often. So what I would recommend is taking a look at ResearchNet and look at the funding announcements and sign up for different institutes for their newsletters where they release information. The ones that we often are, often paying attention to are the Institute for Health Services Policy Research, the Institute for Population and Public Health, but also specific institutes depending on your area. There's an Institute for Infections and
yeah, and there could be non-CIHR calls as well. Like, sometimes the Association of Rheumatology puts out something or something of that nature. And you can, if that's the relevant for your disease interest, or you could make it relevant because what you're interested in is intervention, you can build your team to take advantage of that call.
Exactly. Many of us are in spaces that have funding for things like pilot work, whether it's from your local department or local research institute or local hospital. For those who are in Ontario, and about 40% of the people here are from Ontario, many of us are part of academic health science centers that have access to things like AFP funding. For those of you who are physicians, there's specific funding from, say, Physician Services Incorporated or PSI Foundation or the CMA or others. So it's usually working with a variety of people in your network to learn about these calls. But I think what Noah mentioned about being ready is often key. I'm sure many of you have heard this, which is have your grant idea ready and a proposal kind of drafted even before a call, and just have it ready so you're ready to go. In fact, after today's panel, the last part of today will be people working on a proposal so that they have that kind of developed and ready. So I'm going to turn it over to Dr. Michelle Griever now. to share her thoughts.
Okay, let's see. Can you see my screen? Yeah, okay.
Yes.
Yes.
I'll talk a little bit about some of the infrastructure needed to help with this. So as many of you know, I work with Andrew and others, and I've had the pleasure of working with Noah as well, UTOPIAN's director. So UTOPIAN is a practice-based research network. So you can see two of our founders here, established in 2013. And really its purpose is to provide support for primary care clinical research, because as you've heard, it's hard to do this. It may be hard for somebody just starting to build a team. So where do you go to do all that? A good place to go is build a network that is built actually to support this type of thing. And this is the our network at the Department of Family and Community Medicine at the University of Toronto. So the two arms really are data and research. For the research, we have a primary care clinical trials group. Thank you for leading this, Andrew. It meets monthly. You can see the URL below. This is really to talk about how to do things. I think it's wonderful that so many are taking this webinar, but there's additional supports needed. So this is a place to meet with other people interested, to build your team, if you want to have links to researchers and innovative studies. And we also have several people that come because they're interested in participating as a site. So as Aisha and Noah really rightly mentioned, recruiting is really hard. So if we have people interested as sites, there's now a checklist that's been developed through this group. And if they have a good experience with one study, they're often much more likely to participate in other studies. So this is a bit of help with methods and help with recruitment. I'm not going to repeat what was said. This is the URL for CIHR. Really choose a good question. That's probably the most important part. Your pickup, your trial management, choose your team. And again, participating in something like this is a good way to meet other people, because you will need a team. I cannot emphasize that enough. Content expert, method expert, patient partners now, knowledge users, etc. And then once you have all that, you're ready to write the grant. So I'm going to provide an example of an RCT. This is SPIDER, safety prescribing for complex older patients. And this came about because of a special call. So again, look for special calls. It was through something called a PIN, Primary and Integrated Healthcare Innovations Network. So specifically for primary care research, took advantage of that and applied to CIHR. What's the question? Well, addressing polypharmacies. Here you see some stats on number of older patients who take a lot of drugs, at least 5 drugs. And you can see that, about a quarter of all older Canadians are on 10 or more medications. So the concept was, well, can we do something about this? Can we address this? Right? Canada's fairly high in terms of medication. So how do we address this? This led to a lot of discussion within the trial team. And really we thought, well, we could probably use what already exists, as Noah mentioned, which is quality improvement initiatives. Our departments have very often very robust QI teams. So we use QI methods, audit and feedback using EMR data, learning collaboratives, and coaching, right? And the outcome was stopping potentially inappropriate medications. Why did we choose these class of medication for our classes? Because we already have guidelines, we have tools, etc. So as Noah said, don't reinvent the wheel, use what is already in existence. And this was a structured process, so we provided all 3. Why do this? Well, if it works, you can use the same thing for other concerns, and you can also provide an argument to policymakers that it makes sense to fund QI in primary care to support better care. QI is usually funded in hospitals, etc. There's quite a bit of support for that. We have much less support in family medicine. Because of that, we wanted to test this in regular family practices. So there are a lot of challenges in doing that. not least of which, as both Aisha and Noah mentioned, recruitment. When measuring your outcomes, there are several ways to measure that: surveys, interviews, etc. We decided for the primary outcome to use something that was already being collected. So medication prescribing is routinely collected in EMRs, electronic medical records, and we collect this data. So the cost of looking for the primary outcome was greatly reduced because we did not have to collect that de novo. We are collecting patient surveys, etc. So there are additional costs, but this just comes in. So, this is not something that you have to put a lot of effort in. This is what the trial looks like. What I would like to point out is we got funded to do the feasibility phase, which is really your pilot. And again, it is very important to do that because you don't want to have a big trial where you suddenly do an intervention that may not be feasible. You try to collect your information, and there may be difficulties that are not anticipated. I will say, even with fairly robust feasibility phase, so this was done in 3 provinces, we still hit unanticipated issues like the pandemic. So the feasibility was done and completed before the pandemic, but now we're hitting, of course, the usual difficulties with the RCT. So you have to look back at your protocol, look back at your plan, and address difficulties. We recently received additional funding, so SPIDER is ongoing as part of the next phase of the PICIN, which is called the Primary Care Research Network. So this is ongoing. We are planning to recruit 70 sites. So you can see this is a very large trial. We've hit 42 already, and we are engaging 3 additional networks to recruit to target. So I'm just going to repeat this. The first step is, of course, choose something that makes a difference, an important question. So if you're going to put all that time and all that effort into a trial, and it is a huge amount of time and effort, pick something that you think will make a difference. Think about the aims, what it is that you're going to be doing. So pick up. Obviously something very basic. Really key to have a good trial management team. Choose your team carefully. You can go back to practice-based research networks because we are gaining additional experience in trial management, and I expect as part of the very large Canada to have more experience. In Canada, we do very little research and routine primary care practices. There are many reasons for that, as Noah mentioned, the lack of support, etc. But that also means that if we do not do trials where care is actually delivered, we will not be able to build the evidence that is relevant to primary care. So yes, it's difficult. Yes, there are many, many barriers to engaging practices and recruitment. It is also important to do this. And the more trials are done in primary care, the more experience we gain, and also the more team members we have to engage. So you do not have to do this by yourself. If this is your first time writing a trial, considering a trial, think about and leveraging the experience that has already been done, and practice-based research network like UTOPIAN and now our provincial collaborative Poplar is a good way to do this. And then finally, write the grant. CIHR has lots and lots of information on how to write a grant. One final thing that I will say is our colleagues elsewhere, international trials, are quite willing to share information. So you may not have to reinvent everything. For several of the large trials, for example, we're just about to complete a trial of advanced care planning. The trial writing team, the main trial writing team is in the US, and they invited Canadians to join. So this is $8 million from Picori. You can join others, but you do need to start with a pilot trial. And again, leverage the infrastructure and the experience that has already been built, so that you do not have to reinvent the wheel on your own. Okay, I think that's all I have to say.